Okay, this is the cardiovascular of the CPT 2020 cardiovascular section. As with all of the surgical sections, it starts with your index, some good illustrations. These illustrations help me when I have to kind of get my mind around how the blood flows, artery going to the lungs, veins coming back in, that type of thing, where your valves are. It's very handy. I have heard a lot of my students say that the index here for this section, actually fairly long term, is helpful. So I would recommend getting probably used to using it, although for the purpose of the board you're going to have multiple choice, so it isn't really going to, using the index is only going to slow you down. You're going to want to go to those groupings of codes and then either rule in or rule out those codes. Here's some good artery, vein. Arteries are red, veins are blue. One carries blood away from the heart. Arteries, A for away. Veins carry blood to the heart. They return it to the heart. More good pictures. This helps getting your mind around when we get to the central venous access page. This kind of helps looking at your subclavian vein when central lines are placed, whether it's an art line or a vein line. This kind of helps a little bit. And then these are your different lymph nodes. Lymph node is a circulatory system, just like the blood flow is a circulatory system. It's just a closed system. Your blood, your vascular system, you can access by IVs and that kind of thing easily. It's painful, but it's easy. The lymph system is a circulatory system, but it's closed, and it's a closed system that circulates your lymph fluids, that type of thing. Okay, so now let's get an overview of this section. I would like to start with, don't let this section be too intimidating for you. This section can be intimidating for all of us. There are some sections that are not readily used, or not as used as much. They're just sections to know that they're there. You don't have to master every single code in here. You don't have to have a complete understanding of the disease process. So I think what is best, we'll kind of go over what's in here. What is key is understanding, are we dealing with the cardio, the heart side, or the vascular side? So that you really need to kind of get a hold of, and then break down your foundation from there. So the cardiovascular system in the CPT starts with the heart and pericardium. Peri means around, cardium, heart. So the pericardium is the baggie, the sac around the heart. So specifically, these first codes here deal exclusively with the pericardium. So it is like every section, but I can't tell you, as we progress in the CPT, how important it is to read your parentheses. CPT is absolutely built on parentheses. So starts out, the very first codes has a parentheses above it. For the VATs, see these other codes. Okay, so really, really read stuff. It lets you know what codes maybe are deleted, what codes you need to code in addition. Conversely, if you look underneath code 33016, it tells you don't use these radiology codes in conjunction with 33016 because they've added imaging guidance to it. They've added that. Okay, pacemakers, a big section. Lots of people have them, or they have the defibrillators. So when you have big sections like this, they usually have a lot of wordy stuff in them. So what does this wordy stuff tell you? Well, it's going to define for you what a pacemaker system is, what a system to the CPT, what is included in that, whether it's a single chamber, a dual chamber. Kind of has some really good explanations in here. Then moves over to a defibrillator, that kind of stuff. Does allude to if there's a heart catheterization involved in what you're doing, helps you find those codes a little easier and tells you to go code that extra. What is nice of the last, 4 or 5 years, they've added this table. And I used to have to go in and take every code and start labeling it, bracket off stuff. I don't have to do that as much because I have this table. So before we talk about the table, one more thing. Over here, they have definitions for your leads: single lead, dual lead, and multiple lead. Lead is also a word for electrode. This is very important that you understand what they're talking about here. So that's where the definitions really come to play. So just like in some of the other sections, I have kind of narrowed 2, 3, 4 bits of information I need to be able to glean out of the op note in order to be able to plug the information in and get an accurate code. First is the pacemaker temporary or permanent, or is the defibrillator temporary or permanent? So maybe the first is it a pacemaker or defibrillator? Then is it temporary or permanent? That's up here. Then is it a single lead or a dual lead? If it's single, is it just to the atrium or the ventricles? If it's dual, is it to the atrium and the ventricles? Is it just to the atria? Is it just to the ventricles? And then what was the approach? And we'll talk about approach in just a second. I'll show you the difference. They can crack your chest open and do it, or they can do it like most times, do it through the vascular system. Okay, so now let's look at this table, because this table really does have all the information, has all these codes dumped into it. So if we can readily understand it, then it's going to make it a shorter process to find the correct code. So first, here's your system. So you've got a pacemaker column and a defibrillator column. So if you're only dealing with pacemakers, only look at that column. It cuts a whole column out of the running. I do always put myself a reminder up here that pulse generator means it's the battery. It's just a fancy name. So as we look at some of these codes, the lines, some of them are for lead only or electrode only. That's how these first 4 are. Then it's battery only. Then we're putting stuff in initially. So this 33206 or 33207 is an initial, that's the first time, pulse generator insertion or replacement, plus 1 lead, a single lead. So then you would have to determine, is it atrium or ventricle? Then we have dual leads, multi-leads, then we're into a defibrillator. And this is an insertion of a defibrillator. And of course you see there's an NA in the pacemaker column because you got to come over here for defibrillator. There's a choice here for permanent leadless pacemaker. These are upgrades from a single system to a dual system, either pacemaker or defibrillator. Then we have a series of removal codes. We have some removal of lead-only codes. This was insertion. This is removal. And then we kind of have some catch-all at the bottom. CPT loves a catch-all, loves an introduction, loves another procedures, loves a place just to throw some codes. And there's a need for that, but it drives us nuts as coders. Okay, so that's kind of the pacemakers and defibrillators summed up. So let's move along. We're still under the heart. So this is still cardio, not the vascular yet. These are all of those codes from the table kind of divided up. Really good information, pictures that will help you. Same thing with your biventricular pacing. I do keep a note up here. If you had threshold testing at the time of insertion, you would code that in addition, and that's 93641. These kinds of notes really help me not miss a code. If I didn't have that, and maybe I didn't catch one of the parentheses, I would miss that. So threshold testing at the time of insertion, and there again, that would be documented in your op note. 93641. All right. More defibrillator stuff. These are just more of the codes, more variations to it. Insertion of subcutaneous implantable defibrillator electrode. You see just more stuff. Oh, that page doesn't want to. Okay, so then we get into electrophysiologic op procedures. So let's talk a minute about what electrophysiologic is. Physiologic is a function. So you take anatomy, that tells you the body part. Physiology tells you the function of that body part. So this is electrophysiologic. So if we break that down, we know our body part's the heart. So this is telling us the electrical function of the heart. So in here, we're going to see a lot of ablations. That's a very, very common term. So, and if you see, I have ablation, lots of places, just underlined, just to kind of keep my eyes flowing. So an ablation on a heart regarding electrical activity means they've gone into the heart, probably the surface of the heart, not necessarily, maybe gone to the SA node or the AV node, and maybe it fires inappropriately. It doesn't fire at all. But the impulses that get to it because it isn't firing stay there and don't go on to the rest of the heart. Whatever that electrical current function is, ablation goes in and destroys something. So most likely the electrical function is not working properly, and you have to have it either a different pathway for the electrical current, or it gets destroyed. A lot of times when the SA node and AV nodes get, quote, ablated or destroyed, the patient may end up on a pacemaker because that's the hub of electricity. So that's just a byproduct of that. Heart rhythms, hemodynamic monitors. This is, again, in the heart, but you're very specific to what you're looking at. Then we move into the valves. So you have 4 valves. For me, I can actually, let's get back to this valve page. And what I'm fixing to say isn't very nice, but a paramedic years ago taught this to me, and even in my nursing, that's just what I remembered. So here is a great view of the heart. This is looking at the patient. So the patient's laying on a table, and we're looking directly at the heart. So here's the tricuspid valve, making sure it's pointing. So here's the tricuspid valve. This going out is the pulmonary valve. Coming back in from the heart is the mitral valve. And then you flow back out, and it's the aortic valve. So we have a T for tricuspid, P for pulmonary, M for mitral, and then swing around. I'm trying to kind of help you flow. Swing around to A. So, and again, this is what a paramedic taught me, but this is how you can remember your order. So toilet, T for tricuspid, toilet, paper, P for pulmonary, M for mitral, my, A for aortic, ass. So toilet, paper, my, ass. That's how you can remember the valves. It is not nice. I warned you, and you please don't give me bad words about it. I'm not trying to be ugly, but that really does help you remember those valves. And so the toilet and the paper are on the left side of the heart. Wait, I just told you wrong. They're on the right side of the heart. That's what I get looking at stuff opposite. So they would be on the right side of the patient's heart. That gets me looking at it wrong. And then my ass is on the left side of the heart, which is really where the blood comes into the heart here, goes into the lungs to get oxygen over here, comes back. So it goes out through the artery, because remember, arteries always take blood away from the heart. So it goes through the pulmonary artery into the lungs, gets all the oxygen, comes back into the left atrium, down into the left ventricle, and out through the aorta to the rest of the body. So this left ventricle is a vital part of the heart, because it actually will be the part of the heart that gives the beat that pushes the blood out through the aortic valve into the rest of the body. So sorry, I got my left and rights mixed up. You talking about it. If it was on a patient, I think I wouldn't have gotten them switched. But nonetheless, that is how the heart is. So here are the heart valves. So this area is the aortic valve. I always put I don't know that it's pertinent at all, but I always remind myself it's a semilunar. I don't know why I do that, but I do. I'm sure I had a purpose for it years ago, and it seems like I always come back to, the semilunar valve. Yeah, that's the aortic. We have a couple of those. Great information here into the different procedures that you may see done. Here is your procedures. Your TAVIs are the transcatheter aortic valve replacements. Valve replacements used to, and they are still on some people, but they really have gone a long way in being able to make smaller incisions, not having to completely crack the chest in order to perform valve replacements. They've really gone a long way. So this is the aortic valve. Here's your mitral valve, so anything that gets done to the mitral valve. Here's your tricuspid valve. There's only just a few procedures for that. Then your pulmonary valve. Your pulmonary valve is semilunar again, but that probably is not even pertinent information. It's just something I write down. These instructions very much tell you what's bundled in or what should not be reported with the code. So that's how you know that they're bundled in. So it's very important that you read these guidelines and apply it to the code. Whether your contrast is involved, your fluoroscopy is involved, or bundled heart caths, that kind of thing. It will really help you. Now we're going to get into the coronary artery bypass grafts. These are what I call the cabbages. Everybody calls them a cabbage, coronary artery bypass grafts. And there's 3 ways that you can have it. And you've got to understand the combinations or you're going to assign your codes wrong. So we'll come back to this code in a minute. But let's talk about the 3 areas. So you have a venous grafting. So if every one of the grafts that the provider, the surgeon used were of vein origin, this is the only place that you would go. Vein only. So looking down here at codes 33510, maybe your documentation says the surgeon performed 2 venous grafts. Done. That's it. So this would be 33511, 2 coronary venous grafts. Generally, that's not the case. I'm just telling you, but that's an example of using that. Then we have a combined, and I got to turn the page. This is in a bad place. You've got to kind of turn the page to get to these. If you see, all of these are add-on codes. So they have to piggyback on something else. But these are all vein grafts. And the reason that they're piggybacks is the third area is arterial grafts here. So just like we had vein only, we can have artery only. So very, very common when they cut through the sternum, they harvest the mammary artery, very, very common, and they use it if they can. So if the patient had a mammary artery graft put in and it was only a single bypass, then you would use only from artery 33533. That would be a one artery only. Now, most of the time, you have use of that mammary artery. They're not going to throw away a good vessel. So you're going to have use of that artery, and they're going to take from the saphenous veins in legs. Remember back, think about your grandparents that maybe had bypasses back in the 80s and 90s. That was heavy when I was nursing. And they would have the big long scars on their legs. So they had their saphenous vein harvested for their bypass. So if you have a mixture of artery and vein for your coronary artery bypass graft, you take however many artery grafts from here, and then you use these add-on codes. You piggyback your however many veins. What you must never, ever, ever do is use together your arteries and these veins. The only veins that you can use is from the combined add-on, and that is where they're going to try to trick you on the board. Okay, now I'm going to go back, since we've talked about harvesting the saphenous vein. If you look at this endoscopy code, this is a fairly new technique, maybe the last 10 years. If they use a scope to determine the best part of the saphenous vein to harvest, which ultimately means that your patient isn't going to have an incision potentially from their groin to their ankle, like it used to be, then you use this add-on code 33508. So if you can tell that they used a scope to check in to harvest, or to check and see what part of the saphenous vein they want to harvest, then this is an automatic add-on code. All right, I put an extra note here with the artery that says if combined with vein, then you code that 33517 to 33522. That just kind of helps me know. I also have a note down here because I'm bad about hic picks and I'm bad about the lefts and the rights. I know this. It's just a weakness I have, that you have to use the hic pick modifiers. What I mean by that is if we go back to the very front, this is a great sheet. If we go back to the very front, you will have here your right coronary artery, your ramus intermedius coronary artery, your left circumflex is LC. LD is left anterior descending. You have your left main. So this is the hic pix modifiers I'm talking about. So you can keep track, hopefully, of where stents have gone, of where grafts have gone. Okay? Moving on. We're still in the heart. So now we get into kind of some of the, what I think are funky stuff. Very, very specific parts like septal defects. So you have a septum that goes straight down the center of your heart. So these septal defects, a lot of them are congenital. Some of them you grow out of. Some you don't. Some you may not know you have till you're older. Different anomalies. Anomalies mean it wasn't made right. Shunting issues, if there's shunts that have to go in. Transposition of great vessels. That means they're not coming off the heart, off the aorta like they should. We get into thoracic aortic aneurysms here. Pulmonary artery issues, because that's the main artery coming off the heart that takes the blood to the lungs to get oxygen. Then we have a heart-lung transplantation. Clearly very, very specific. If you knew that you were coding a chart that was a heart transplant, this would be the place that you come. It would be very easy to find. Then we have our ECMOs and our ECLSs. Both of these systems are absolute life support. They would not be done if it was not the last resort. They're very hard on the body to survive, but sometimes it's needed, to sustain long enough to build some strength, to do surgery to correct what the problem is, or wait it out to see if the body on itself is going to compensate, and then they can move forward. These are, again, very specific to ECMO and ECLS. You would plug, this is a great table, you would plug the information in depending on the approach, whether it's percutaneous open or through the chest, what the age is, if it's veno-venous or if it's veno-arterial. You just kind of plug it in. So CPT has gone a long way in kind of breaking down some of the harder areas for us so that you can come here and rapidly see, okay, this is really technical. I'm a little out of my comfort zone, but you could see what information that you needed to glean out of the op report, and then you would be able to get it. Cardiac assist. This is used potentially if, say, a patient needs open heart surgery. They've had a big heart attack. They need open heart surgery. Perhaps their heart is just really weak or really sensitive from the heart attack. So they need a few days of rest. So your cardiac assist devices will give that heart, will take 30, 20, 30, 40% of the workload off the heart to allow it to rest for a few days to hopefully build strength so that they could go into surgery and get the real problem fixed. So that's kind of how those are used. Now we are leaving the heart. We are leaving the heart and we are moving into veins and arteries. So everything else is going to be veins and arteries. That was the heart and surrounding structures, blood flow, aorta, because that is directly attached to the heart. Now we're into arteries and veins. So again, it is vital that you know your terms. Ectomy is removal. So embo and thrombo, those are clots. So this is removal of clots. So you have to know, is it arterial, is it vascular, that type of thing. Endovascular repair of AAAs, abdominal aortic aneurysms, and iliac arteries. Endovascular repair is different from open repair. I work in HCCs, risk adjustment. And we can, if we're looking at a chart and the patient has had a repair of a AAA, aortic or abdominal aortic aneurysm, we can code it if they tell us it's endovascular repair. We cannot code it if it was an open or direct repair. And I'm hoping there'll be a picture here. So yes, so here's a great picture. So here is the aneurysm. the blood vessel's gotten all bubbled, ballooned out of shape. So when you do an endovascular repair, you come in and put a sleeve in, or the surgeon does. It leaves that aneurysm sitting there. So the aneurysm technically is still there. They're just bypassing through a sleeve the blood flow so that the blood doesn't go in and make the aneurysm bigger and then it blows like a balloon. In a direct repair, they would not put a sleeve in. They would go in, cut out, sew up. They would completely reduce that aneurysm. So that's why when in a risk adjustment world, if you're trying to code an aneurysm and they put a sleeve in or did the endovascular repair, we can still code it because technically that aneurysm is still sitting right there. So if the sleeve were to move, become ineffective, whatever, that aneurysm still sitting right there. So it would be a problem again. Those are good pictures. Very good pictures. Okay, more pictures of the endovascular repair. Lots of different choices of repairs in there. We're moving into a little bit more technical areas. So for me, I like to keep it simple. We're still in aneurysms. You've got to know your repairs. You've got to know your location of the aneurysms. That's it in a nutshell. So this is direct repair. That was endovascular. Now we're into direct repair. So that's the difference in the two sections. Direct repair means they're opening you up and cutting it out. Excuse me. Thromboendarterectomy. These are very common for carotids. That's probably about your most common body part, carotids. You get a little bit of plaque in your carotids. Once it gets to 70, 80, they're probably going to start wanting to talk about help taking it out or providing a stent or something. Thrombo means blood clot. Generally for carotids, it's athero. So that means it's plaque related. Here are bypasses. These are not the coronary artery bypass. This is your other vessel bypasses. So I put on here not coronary. If you're dealing with heart bypass, then you've got to be in the other section. If you're dealing with a FemPop behind your knee because of peripheral vascular disease or peripheral artery disease, this is where you're at for the FemPops. Good, very good pictures demonstrating how they're bypassing, using vessels to bypass. The headings in here, I can't really sit and it would take us all day. There's just a lot. I don't even know how to say it. There's a lot catch-all in here. So you've got to get familiar with the big headings, your body parts, and then it just takes some reading and digging. If you routinely work for a cardiothoracic surgeon, you're probably going to get a fairly rapid exposure to a lot of stuff, or even a vascular surgeon. But you're just in routine and for the purpose of the board, you don't feel like you need to master this down to the wire. Moving on. So now we have some vascular injections. This vascular, one of the pieces of information that you have got to understand is the difference in catheters. You can have a selective catheter or you could have a non-selective catheter. A selective catheter means the surgeon can put it maybe up through the groin, through the femoral artery. And once he gets to wherever he's looking, whatever branch of the vascular family he's looking at, he can select which direction he goes. And he can wind through. It's a different kind of catheter. A non-selective catheter means he can still go through the groin, go up to the vessel, but it's like a flashlight. Wherever that vessel, whatever that vessel is looking at, the flashlight range is all he can see. He cannot select different paths and a different viewing. So if you look in here, you can see the difference. Some are selective catheters, and then you'll see non-selective. I'm going to see if I can find one. Selective. Most of them are selective anymore. As we're looking, I'm on page 264, and you're going to see selective catheter placement artery system within a vascular family. And this is first, second order, initial third order, additional second, third, and beyond. So let's talk just a minute about this, because this is where back here, I think it's Appendix L. I just gotta find my page, my ranges. F, G, I, J, K, L. I gotta do my alphabet, sorry. Okay, so here in your appendix is Appendix L, vascular families. So we're here in cardiovascular, page 264, starting with codes 36200, and they're talking about vascular families, first order, second order, third order. So what that means is that this absolutely is your key to understanding what you're doing. So you have a scenario that starts in the innominate brachiocephalic. That is under a first order. And they go into the right subclavian. So that is a second order. And then they stop at the right vertebral. That is a third order. So you have your first, second, and third. Let's do another one. Let's go over here. Let's say through the abdominal aorta, they go into the cephalic. That's a first order. Then they go to the common hepatic. That's a second order. Then they go to the greater pancreatic. That is a third order. From there, they go to the transverse pancreatic. That would be a beyond third order. So that's how you figure it out. So I would spend some time in Appendix L. Don't memorize. There's no need to memorize stuff. What there is a need for is a comfort reading this, a comfort seeing a scenario and pulling out the information and plugging in here. So how does Appendix L work here? So say they started, they just went into the cephalic. So this is the brachiocephalic. So this is our first scenario. Here's a non-selective catheter. We were looking for one of those. You do have to look in here to make sure that your first order is thoracic or brachiocephalic. Your catheter placement would be common carotid and nominate. Here's another common and a nominate. Internal carotid, that subclavian. So you have to kind of find your body part first, then plug it in. Know what your catheter is, selective or non-selective. And then you just work down from there, first order, second order, third order, or beyond. Venous puncture, 36400. This is a venipuncture. You do not, this is not your routine venipuncture. This is specific to a kid younger than 3 years has to be a doc doing it. A nurse would not be doing it, and this would be femoral or jugular. Your blood transfusions, 36430. You're not going to count the units here. It's just the active hanging blood. They could hang 5 units. It's all the same code. 1 unit, 5 units, 10 units. Oh, patient may be dead. Okay, I'm on page 270. Let's talk about central venous access. So, again, this is an area where there's 4 or 5 pieces of information you're going to have in order to find the right code. First of all, let's talk about what central venous access is. So, if a doctor needs good solid access, this is not an IV, good solid access to the central venous system. Okay? If you see, we're talking all as direct into the vein system, maybe inferior vena cava, as you can get. This is not just a regular IV that a nurse starts in the ER. This is provider placed. This is the area where you're going to get those codes. So first piece of information you're going to need to figure out is it tunneled or non-tunneled? So tunneled means maybe they've tapped in low and come up and tunneled under the skin and came up, or they've tapped in high and then tunneled into the sub-Q and came out low. So you have to have proof of that. These are non-tunneled. They're tapping directly in. Do you see the little pigtail? That is exactly where they've tapped in. Here is a tunneled. So here's the entry site here, but it's tunneled and actually comes out way down here. So that's the difference. So you need to know, is it tunneled or non-tunneled? Was it central or peripheral? Now don't get the central mixed up with central venous access. Central venous access is accessing directly to the central venous system. You can do that 2 ways, centrally located or peripherally located. Peripheral is anything off the trunk. So the trunk being below the neck, not the arms, not the legs. So that's the trunk, just that square. So if it's centrally located, that means your tap is directly on the trunk of the body. If it's peripheral, it could be on an arm, on a leg, high on a neck. Necks are peripheral, believe it or not. Okay, then what is the age of the patient? These codes will be divided by age. I think 5, younger than 5, and then older. And then was there a port or a pump? So that's the information you're going to need to have to be able to plug these in. And once you have that information, you're just reading and plugging in. If you want to go through here and underline the non-tunneled compared to the tunneled, you certainly can. If you want to underline the centrally inserted or peripherally inserted, you can. But really sit and think through all the words. A lot of folks get centrally inserted and central venous system confused, which is easy to do. Also in here, if they use fluoroscopic guidance, you're going to want to use 77001. Again, I have to tell myself that so that I don't forget a code. And also, once they get the access, if they hook up IVs or do any IV pushes, you're going to need to code those in addition as well. We haven't covered those yet, but you would need to. That's in the medicine section. So with this section has really good, this is talking about the different port and how you've seen kids or family members that had little ports so they don't have to always stick you. This is a great table for this. So as you can see, it helps divide it. Your tunneled, your non-tunneled, your centrally tunneled, your peripheral, your ages, with and without guidance. Is it an insertion? Is it a repair? Is it a removal? This is a great table to take all of these codes and kind of infuse them into one page. So get familiar with this. I don't have a lot of notes to put on here because if you just get familiar with it, it's the information is there. The book's smarter than I am. I learned that a long time ago. The ICD-10's way smarter than I am. Okay, so then we're going to get into a hemodialysis. So this is folks with kidney problems. This is a hemodialysis area. One of the key things to know for any kind of long-term or sustained dialysis is they put in AV fistulas. That's what they're called. Arteriovenous fistulas. So they combine the vein and the artery systems so that when you're sitting in dialysis or the patient is sitting in dialysis for 3 or 4 hours, their blood's being filtered because their kidneys can't filter it. And so it's being filtered by a machine. And so these fistulas allow the blood to be taken out and returned in a more rapid manner. Okay. Lots and lots of dialysis information in here. Yes, it's worth a read. It's pretty technical. For me, if I were just new starting out, I would get a comfort level with the words, the phrases, the lingo that they're using, so that when they say AV grafts or AV fistula, I know what that means. Those are one and the same, that kind of stuff. This is a good place, like most of the guidelines in CPT, that will help you not miss a code. They're reminding you, hey, you need to add this on if it happened. So it is important to be somewhat familiar, but this is very, very, very technical, very specialized. Code 36901, the graft for this code is already present. I make that note because I have at times wanted to add that code or add for the graft, and it's already there. Transcatheter procedures. This is going to be removal of plaque, removal of blood vessels, blood clots. Sorry. Transcatheter procedures, and you can see mechanical thrombectomy. Mechanical means they're removing it. You physically have to go in, have the mechanics to remove the blood vessel, whether it's arterial or venous, artery, venous. Other procedures, this is a catch-all, and there's no way that you would be able to have all of this memorized. I will say in this area is when they have the thrombolysis. So maybe patients come in, stroke-like symptoms, they've determined that they have a clot, and so it's within the time frame that they can do a clot buster. And this is potentially an area where you might find some of those codes. Endovascular and revascularization is in here. Typically, this is your lower part of the body. If you look at your body areas, this is talking about a tibia, femoral, iliac. This is pelvis, lower legs. Lots of folks, for whatever reason, build plaque naturally. Smoked a lot and have quit now, which is great, but damage was done or the vessels were harder, so they built up plaque easier, that kind of thing. That's all of this. Great pictures. All of this has to do with that catheter placement. There's different balloonings for the lower leg stents and stuff. They show how they put balloons in, inflate it so that it pushes that plaque into the side of the wall vessel. Put in stents. Intravascular ultrasound services. So there again, this is very specific. So if you're looking for inside the vessel ultrasound, this is where you would come and just kind of plug your stuff in. At the back of the cardiovascular section, we have a hemolytic and lymphatic system. Just a couple of pages. Starts with the spleen. Spleen is a vascular organ, so that's why it's here. So any ruptured spleen, spleen that needs to be taken out, that's all going to be in here. You need to know your approach. You can have it open or you can have it laparoscopic. Always know your approach. Then there's just a general section. So spleen wouldn't be in here. This is more general. Bone marrow, stem cells. This is showing harvesting or taking a needle biopsy of your bone marrow. They're making it look very easy. Transplantation of stem cells. This is specific to your lymph nodes and your lymphatic channels. Remember, your lymph node, your lymphatic system is a closed circulatory system. So the fluid circulates just like blood would. You just can't tap into it like you could with the vascular system. Again, know your approach. Excision is open. Laparoscopic is by way of a scope. Couple of notes in here. By code 38505, code also if they put in markers for the blue sentinel node, that's 38792. I always make myself notes like that. 38720, cervical lymphadenectomy complete. Doctors may also call this radical. We get to, so here's your 38792 that we wrote the note about. And then mediastinum, very, very specific to just that breastbone. Incision, excision, scope. And then we're done with diaphragm, and then we're done with this section. Very involved section, and I know that. So let's do a little bit of drilling. What do I think? Let's see. Let's do 18-year-old patient underwent repair of ductus arteriosus. This is where you might need to get a piece of paper out, and as I'm talking, jot it down so we can, in fact, I'll just do it while we're, show you how I would do it. Okay, so this is 18-year-old. I don't know if we need that information or not. So it's a repair, ductus arteriosus. The approach was posterolateral. So this is from the back and side. Thoracotomy. Otomy means cutting into. Thora means chest. Okay, so let's see if we, I don't know how to keep that out. Let's see if we can find that. So this is going to be on the heart. So we're on our heart section. We have to get to those. This is that section past the valves that was the blood vessel fixing the anomalies and stuff. A ductus arteriosus on an 18-year-old would be an anomaly. So we've got to get to that section. There's going to be a ductus arteriosus section. I just got to find it. Okay, so we're getting close. This is transposition of, here's a patent ductus arteriosus. So Repair, so here, 33820. Repair of patent ductus arteriosus by ligation. Why? This is a repair. Ligation is just a tying off. This is a full-fledged repair, so it's probably going to be a division. So this is younger than 18 by division, 18 and older. So here we go, 33824. 33824. The posterolateral indicated that it was not through a scope. So that's how I know that it would not be like down underneath here, a percutaneous catheter closure. They didn't give me that. They said they repaired it. Okay, let's do another one. Patient underwent a CABG. So let's write this down. So this is going to be a CABG. So I know that's going to be my heart. And then I got to go to that coronary artery bypass. And they did one artery. And they did one vein. So we did a combo. So let me get back here. Okay. So here is my CABG. Starts with vein, my combined, and my artery. So when I have them combined like this, I code my artery first. So I'm going to come to artery, coronary artery bypass. 1. So that's going to be 33533. Then I have to use my add-on for my vein. So I come over here to my add-ons. This is for one vein graft, 33517. So that's my codes. Okay, let's do another one. Let's see. Patient underwent insertion of permanent pacemaker. What do we know about it? Transvenous electrode ventricular. So we have ventricular electrode. What else do we know? Additional electrode was inserted in the left. So we have plus a left vent. So this must have been the right. So now we have 2 electrodes, ventricular. So an additional electrode was inserted in the left ventricle to provide biventricular. So that's also a dual chamber. Pacing system and attached to the inserted pacemaker. So let's see what we have. So let's get to pacemakers. And I am going to that table because I love that table. So first I have to insert it. So we have insertion of a permanent pacemaker. So I'm going to go to insertion. Single lead ventricular. So that's 33207. And then we added another ventricular lead. And I got to see where my added lead is. Insert venous, multiple leads. Insert venous dual leads without pulse generator. So here's my second. So 33217. So you would have 2 codes for that one. All under pacemaker. Okay, let's do one more. Operative ablation, that's my word, ablation. I don't know of what yet, but that's my word. Of ventricular rhythm, so I have a vent rhythm. Performed on 62-year-old woman with cardiopulmonary bypass. With cardio bypass. Okay, so that's the key information. So now I have to get to that electrophysiologic area. So let me get there. Oh, I think it's back here. Maybe I passed it and I didn't know it. Okay, I did. Electrophysiologic. Remember, that's where we're going to see all of our ablations. So now I need ablation for ventricular atherogenic focus. So let's see. So I need ablation supraventricular. Supra means above, so that's not it. Ablation reconstruction of atria. Atria, this is all the top of the heart. Ventricles are the bottom of the heart. These are all add-ons. I can't use them anyway. Operative ablation of ventricular arrhythmogenic focus with cardiopulmonary bypass. There we go. We got all of it in one code. I wasn't sure if it would be in one code. So 33261 is our code for that. Yay. Okay, let's keep going. Physician drained fluid from the pericardial space under ultrasonic guidance. So our body part, pericardium, however you want to say it, and they drained fluid and they used ultrasonic guidance. And forgive how I write stuff out, but time is usually of the essence when we're trying to find this stuff. So let's see. Where is that going to be? Probably in a introduction. It's not going to be with pacemakers. Let me look before pacemakers because it's pericardium. I had to find my body part. So here's my body part. We're going to drain fluid. So pericardiocentesis. Centesis means draining of fluid. That's another suffix. Pericardio is the pericardium, including imaging guidance when performed. So 33016 is your code. I don't include any other codes. It's telling me not to. That's everything. Physician repaired an atrial septal defect. So this is a septal defect. And a ventricular defect with a patch. So let me read that again, but I think this is the information I need. The physician repaired an atrial septal defect and ventricular septal defect with a patch closure. So let's get to that area. Remember, that's going to be after your cabbages. We're still on the heart because the septum is the center part of the heart. So let's get past this stuff. Here's our septal defects. I know we have a section on this. So now we have to find a code that hopefully includes both the atria and the ventricles. So this is a direct repair, secundum, that's not it, direct patch closure, sinus venosus, repair of atrial septal defect and ventricular septal defect with direct or patch closure. Oh, that's our code. Love it when it all. What I don't like is when you go to plug in all the information and there's just one piece, it just doesn't feel right. I hate that. So I always do kind of make sure, I always read, even though I'm almost positive we're right, I want to read these parentheses. Do not report as 63. Okay, I wasn't gonna. For repair of tricuspid, okay, this wasn't tricuspid. And I just kind of, yep, I think that's good. That's just a good habit to get in, to kind of read around, always read the parentheses. Once you found the code, if there's parentheses, read them. I'm telling you, they will save you. Okay, let's do some central venous access because those can get kind of tricky. So let's plug our stuff in. using the pieces of information that we know that we need. Oops. Hold on, let me find my... I want to show you also in your 321 coded book, this is on page 577, they have a great table. Just like in our CPT, it's just laid out a little different. So I wanted to show you that. It's a good table. Very, very good table. Okay, so now let's do another drill on central venous access. And I got to turn that the right way because I'm type A. A physician performs a right upper extremity arteriogram. Catheter is inserted into the right brachial artery. So this is a right upper extremity arteriogram. Guess I probably need to write that too. Catheter is inserted in the right brachial artery. Not sure I need brachial. Pretty sure I'm going to need artery because it could be artery or vein. So this is not quite central venous, but we're getting closer. So let's go to that section. And most likely we're going to have to go to, and this is something you wouldn't naturally know, and that's one of the reasons why I wanted to have this example. So here we are. Let's look at our section. So we're doing vascular injections. Arteriogram is an injection. We're going to have to inject dye for the doctor to be able to evaluate. So this is arterial. So let's keep going with arterial. They are talking about arteriogram and angiogram sometimes are used synonymously. So let's keep going. Or not. I need my injection. And I should have stayed right here. So here is my injection of the dye. 36140, introduction of needle or catheter, upper or lower extremity artery. So this is an upper artery. So my injection of dye is 36140. Now, nowhere here is it telling me that I need to go to radiology. But let me tell you, I'm just going to give you the code and I'm going to show you how they fit together. So it's 75710. So go to 75710. And in just a couple of weeks, we'll be in this section and you'll see. So what section am I in back here? I'm in vascular procedures in the radiology section. Vascular procedures. We know it's artery. Artery. So 75710. Here is an angiography, extremity, unilateral. Unilateral means either the left or the right, not both. So that is correct. This is the radiological supervision and interpretation. So and I refrained from writing notes here just to be able to demonstrate this. So once you're familiar with your radiology section, you'll know this whole section are your graphs or your pictures of the artery and veins. This is the radiological side of it. You have to have the injection component, but this is the radiographical section of it. So this would be the right code. I would write in here code also injection of dye or introduction of catheter. So this is the supervision and interpretation of the pictures. It doesn't include the catheter that gets to the body part that they can take pictures of. So this angiography would be considered the big dog. That's the actual procedure. Introducing the catheter was a means to an end. So you would code the 75710, the actual angiography first. Then you would code the introduction of the catheter, which would include the dye, as the 36140. This is a hard one. So maybe here you need to write code first so that you would know your sequence. Code first graphy, that's what I would put, in rad. So then that triggers your mind. Hey, if I'm picking something here, my big dog may be the actual pictures, or the procedure of taking the pictures may actually be someplace else. So that's a good note to tie those two together. Okay, now let's do central venous. So let's get to our central venous. I'm going to go straight to my table that I love. Kind of dark pictures, in my opinion. My eyes are getting old, but it's okay. Okay, so what information do we know? So physician punctures the subclavian vein. So this is subclavian vein of a 4-year-old. Passes a guide wire centrally, so that's telling us we're in the right place, central venous access, and inserts a central venous catheter non-tunneled. So, subclavian vein. So let's go back to the information we need to have. So is it tunneled or non-tunneled? We know it's non-tunneled. Is it central or peripheral? Well, where is that central vein? We have to look. Central vein is right here, or the subclavian vein is right here on the chest. So that's going to be a centrally inserted. And then the patient is 4. So let's look here. So we're under non-tunneled. This is an initial placement. And the patient is under 4. So 36555. Non-tunneled, under 4. Okay, so 36555. Yay! Boy, we're ripping on. Okay, so let's do a few in the lymphatics. Just so we've gotten in there. These lymphatics and the hemolytics kind of get used. Sorry, I keep moving my book around. I don't know why I do that. I get excited. I like coding. I can't help it. These lymphatics get used a lot combined with other stuff. Remember, we came here in when we were doing our breast mastectomy or lumpectomy. I think it was a mastectomy, and we included some lymphadenectomies. Okay, so I always like to be at the beginning of my section. So here we go. Patient underwent bilateral total pelvic lymphadenectomy. I've got to write this down. So total pelvic lymphadenectomy. Okay. Via scope. So via laparoscope. Let's talk about that word. Laparo or laparo, depends on where you're at, means abdomen. So this is a scope in the abdomen. This means this is a laparoscopic approach. That means they're going to use trocars and ports, and they're not going to do an open incision, make a big incision. with multiple peri-aortic lymph node samplings. So we've got some peri-aortic node samples. So let's see what in the world we're going to do with this. So I'm not going to be on spleen. I got to be under my lymph. So let me get over here. So now I'm under my lymph nodes. Our approach is by scope. So I'm not going to be under excision because that's open. So I want to be under laparoscopy. It was a total pelvic lymphadenectomy, bilateral. Oh my gosh. I think I said it but didn't write it down. Oh my gosh, I can't even spell. I got mad at myself. Bilateral, I can write too. Okay, so they did a total bilateral pelvic lymphadenectomy. So here's my scope, surgical retroperitoneal lymph nodes, nope. With bilateral total pelvic lymphadenectomy, that is right, but I wonder if I can find one code that has this peri-aortic node sampling. So with bilateral total pelvic lymphadenectomy with peri-aortic lymph node sampling, single or multiple. So that's it. That's my code, 38572. Now I'm going to look. You see, up here is a parentheses. This book, it's just, page to page, it's a bad, so I got to see if this parentheses has anything to do with my coding. For drainage of lymphocele to peritoneal cavity. No, I don't have any. And then let's look at this code. Bilateral total pelvic lymphadenectomy with the sampling, peritoneal washings, peritoneal, oh, that did a whole lot more than we did. So that is the right code. Okay, let's do one more. Physician sutured lacerations on a ruptured spleen. So this is a ruptured spleen. He repaired lacerations. And then resected and removed a damaged section of the spleen. So resected, removed portion of the spleen. Okay, so now let's get to our body part. So I got to go backwards. I got to get to my spleen. He did not tell me his approach, so it's probably going to be an open. So, or repair, but it's not going to be a scope. So total splenectomy, that is not correct because we only did a portion. Repair of ruptured spleen, and that word splenography, raphy means suture. So we know he repaired lacerations, that would be suturing, so that's correct, with or without partial splenectomy. So that's our code, 38115. Very, very common for the CPT to give you choices with or without. Very, very common. Okay, so that's it. Oh my gosh, we did great this morning. Okay, so that's it for cardiovascular. Yes, there's some really what I would call techie, very, very involved places. We've gotten kind of in it. We've hit the high points. Read your guidelines, know your parentheses, and I'll see you on the next video.